So in case you hadn't noticed, I try to encourage all of the PhDs and students to present. This PhD dug in deep and said, I don't want to present. So Xiaoying, I think, she's done all of the work that I'm about to present on her behalf, but I didn't want to force her too much. So I'm going to be presenting Xiaoying's work on VA-ECMO and Impella, looking at some early mechanistic work, trying to understand renal function in preclinical models of acute MI. So we've talked a little bit about how heart failure interacts with renal dysfunction. This is a very nice review from Jack that just came out about a year ago, looking at cardio-renal syndrome type 1. And the fact that when you have a failing heart, it leads to potentially a failing kidney. And these are all of the things, these nephrotoxic agents that heart failure patients receive. And these are some of the mechanisms, if you start to look into the literature, as to why you may develop kidney damage when you have heart failure. When we think about it from a hemodynamic perspective, I started to think about this a few years ago, and we started just understanding just the anatomy and functional physiology of the kidney again, going back to some of the original texts and some of the original papers that were published. And at the end of the day, the kidney itself is still governed by preload and afterload. Preload in this case, of course, is arterial, afterload is venous, and there's a ureter for another outflow mechanism. So when we have heart failure, there's increased renal vein pressure. There's a reduction in renal arterial pressure. If you have a reduction in your cardiac output, the balance of these two may lead to hypoperfusion of the kidney. And what we see also is that at the glomerular level in the bottom left-hand corner, there is a shift, especially if you start to develop venous congestion. And the venous congestion causes a shift which increases interstitial pressure inside the kidney. And that can start to compress the Bowman's capsule around the glomerulus and start to reduce that GFR propensity. So there's an interaction that's hemodynamically driven in the kidney. And our question was, how did the use of a mechanical support platform impact these hemodynamics? So we, of course, went back to the literature, and there's very little literature out there. This is from John Burnett, put out within the past year, where he created a canine model of heart failure about 3 to 4 weeks later after inducing using microspheres and MI model. Came back and he did one thing that we haven't been doing much of as cardiologists, which is he looked at the kidney. And he created a genomic platform, as you can see here. And what he showed is that there were some interesting differences between the renal cortex and the renal medulla in terms of inflammation, apoptosis, fibrosis. So a real broad look at what's happening in renal remodeling in the setting of heart failure. And one of the things that he identified from this paper, which I think is a good one for us to all think about, KC on these graphs is kidney cortex, KM is kidney medulla. And as you see at the top, there are all various mRNA levels of inflammatory markers, MCP1, IL-6, some of your favorite players may be listed here. And what he started looking at is the impact of heart failure on renal cortex versus renal medulla. And as you can see, there's a significant difference in how the cortex and the medulla respond to the failing heart. So I'd recommend, if you're interested in the field, take a look at this paper. It provided some interesting insight. So when I started to think about the mechanical support area and how it relates to renal function, the Mike Flaherty paper really threw me for a loop because I didn't quite understand it. I still don't understand the mechanism, as the panel discussion just had. And so if we think about it just, again, as a simple cardiologist, preload, afterload, and what are the devices? So IABP, Impella, VA-ECMO, just we would think at the simplest level, increase renal preload by increasing your blood pressure, reducing renal afterload, so maybe the RP would reduce renal vein congestion, tandem RVAD, the VA-ECMO systems, you think you're draining and from the venous side and increasing on the arterial side, so what is the effect? And then, of course, this whole field of neuromodulation and renal denervation fits into this space as well. So when I looked through literature, the only thing that we could find was this minimal impact of balloon pump on renal blood flow, which suggests that if you don't have proper positioning of the balloon pump and it's covering your renal arteries, that's a bad thing in terms of reducing renal blood flow. The only real published data that's out there that I could find, again, was from Moeller and Helgestadt, and basically looking at a small study, but looking at renal blood flow and changes with IABP versus Impella, and a signal of increased renal blood flow, maybe with Impella 2.5, but a small delta, a small change. And then VA-ECMO, there wasn't really much data in terms of hemodynamic effects on the kidney. This was the simplistic setup to just explain in our minds how VA-ECMO may be working. Of course, reminding folks that ECMO is flowing upwards up the aorta, so it's a retrograde flow. And the first exit off of that superhighway is the kidney. And so there's a nice paper, and for all of us in ACURE, as we're thinking about publishing in this space, I think we should start publishing in the Journal of Cardio-Renal Medicine. Vilja and Ronco are two of the leaders in the field. They've written this nice review on ECMO and how it can lead to AKI, hemodynamic variables, hormonal, and pretreatment. And what they show in here is this non-pulsatile flow component, reducing renal blood flow overall, but then as you can see, reducing that ratio of cortical to medullary flow. Again, going back to the Barnett observations, and is that impacting something that we're not aware of? And then this paper from Hiro Takayama showing Columbia that there's about 60% of AKI incidence on VA-ECMO. And he goes on to show that this incidence of AKI actually correlates with increased mortality if you develop AKI on ECMO in cardiogenic shock. And this was the figure showing the correlation with mortality. So what we've started to do is, we've harnessed our animal research facility again, and we have started building out a renal module, which gets, again, fairly sophisticated in terms of the physiology as well as the biology again. And this is just an example of one of the early setups that we were working on. And as the question came up, as we were just testing the pilot setup, here's the renal flow velocity, as you can see. And what we're doing now is we're going to activate ECMO. And so the question that we haven't been able to answer in man, we're now going to at least start getting some data in these animal models. So there we've just activated ECMO, and in the orange and yellow lines at the top, that's the arterial pressure in the aorta. So that's climbing, as you'd expect. But you just notice you lost your flow velocity there. And that's that initial increase in arterial pressure. That's the myogenic response to high pressure that's in the renal artery. And then as you have this buildup of pressure in the aorta, this starts to become overcome. And you start to get this minimal pulse amplitude as you stay on ECMO. And as you start to watch that flow velocity tracing, something very interesting happened as we just sat there and observed this phenomenon. And what you're seeing now is that the flow velocity is starting to come back down again. So what we've done now is observed that we are increasing aortic pressure, but we are reducing renal flow in the artery. And so there is some mechanism that's not quite explained yet. It may be autoregulation, it may be myogenic, it may be a component of tubulo-glomerular feedback. So at the bottom of the slide is my conclusion on the hemodynamics. More to come in the ACURE 2019. We should have this whole package together, but it's a little early. One of the things that we did was in this reperfusion model that you've seen a few times today, we did do urine and plasma sampling. We did it at baseline before the induction of MI. We did it at the 120-minute point after the animals had been on either no pump or Impella or ECMO for 30 minutes. And then we did it at the end of the study after 180 minutes of reperfusion on support for Impella or ECMO and then without support for the control group. And one of the things we wanted to look at was levels of renal injury biomarkers. So in this space, I think this is going to become a very interesting opportunity for translational research. You can measure these biomarkers using simple ELISAs. We just need the blood and urine collected. And you can see where the biomarkers originate in the renal tubule, and you can see some are related to glomerular function, like cystatin C, some are proximal convoluted tubule function, like KIM1, and then NGAL, which is the neutrophil-based gelatinous marker, can come from the proximal as well as distal convoluted tubule. And the reason why this becomes important is if you look at this kinetics curve, which is put out in critical care medicine, after an event like surgery, for example, you see that these biomarkers, NGAL, KIM1, cystatin C, they actually alter before there's an increase in creatinine. And so the creatinine actually occurs at the 24 to 48 hour time point. But these early biomarkers start to go up and start to give you that early measure that you may develop subsequent AKI before your creatinine actually increases. And I think that's where the power of the biomarkers comes into play. So we studied these biomarkers in the models, and we looked at both urine and plasma paired samples at baseline occlusion and reperfusion. There's the control in red, the Impella in blue, and ECMO in green. And as you can see, at the induction of the heart attack after 120 minutes of LED occlusion, and this is after 30 minutes of on pump, the ECMO group in the urine already has a slightly elevated KIM1 level, and the red bar is the control group, and the blue bar Impella, no significant change. But after 180 minutes of reperfusion, now the ischemia reperfusion, the control group in red has elevated its urinary KIM1 level. The ECMO group is also elevated, but the Impella group is going in the other direction. There's a non-significant reduction in urinary KIM-1 levels, but compared to no pump or compared to ECMO, it's a significant reduction. The plasma KIM-1 levels tell a little bit different story. No significant change. There's some large variation in the ECMO group at occlusion, but after 180 minutes of reperfusion, no significant change in plasma KIM-1 levels. We then looked at urinary NGAL, and it's important to know your biomarkers. So the ECMO group had an increase in urinary NGAL levels. Impella and the ischemia reperfusion alone had no change. Importantly, for plasma NGAL is where we saw a difference. And what you see here is that the control arm started to have an increase in plasma NGAL levels after 180 minutes of reperfusion. ECMO and Impella, no significant increase. But it's also important to remember that these come from neutrophils, and when you have an infarct and reperfusion injury, it's mostly driven by neutrophils. So not surprisingly, we're seeing it in the bloodstream, maybe coming from the heart, as opposed to the urine, where it is primarily coming from the kidney. And then the levels of cystatin C, that other marker of glomerular injury, you can see here that in the control arm, there's an increase compared to Impella, but across the board, the Impella urinary cystatin C levels are decreasing after 30 minutes on pump, and then after 180 minutes on persistently on pump. And the plasma cystatin C levels trended together between the groups, but no significant change across the board. So we then said, out of all these biomarkers, the urinary KIM-1 level, the kidney injury marker 1, seems to be a potential early indicator of AKI when you're on acute mechanical support. So we started looking at what is the structure of this protein. This protein is expressed in the proximal convoluted tubule. And as you can see, there's a large extracellular domain, and then there's a small cytoplasmic tail. And it turns out that the extracellular domain gets cleaved and then gets shed into the urine. And what causes the cleavage is activity of matrix metalloproteases. And so what we started to look at is when we activate these pumps or we have a heart attack, are we seeing shedding of KIM-1 into the urine? And that's why the urinary levels are high and the plasma level may be low. And so we started to look at that in more granular detail. So Xiaoying, in all of her work here, essentially looked at a Western blot from protein samples from the renal cortex. And the two antibodies she used, one antibody that binds to the extracellular domain and one that binds to the cytoplasmic tail. And if our shedding hypothesis is correct, then you should lose the extracellular domain into the urine. So what's left in the renal cortex tissue should have less of the extracellular domain. And so that's what we found, is that in the ischemia reperfusion alone, or in the ECMO arm, the extracellular domain was gone from the renal cortex, but the cytoplasmic tail remained intact. And in the Impella group, the extracellular domain was still present, as if it was an uninjured sham kidney model. So one of the mechanisms that we think for this high increase in urinary KIM-1 is that it's being shed from the renal cortex. And remember, the trigger for the shedding is an increased level of matrix metalloproteases. And so the next natural question was, what is the MMP activity? And so I thought I would show basically the data that Xiaoying and my team look at when we have lab meeting. This is non-quantified, but I don't know if it needs quantification. The zymography panel shows it quite well. So what is done here is we load protein samples into each of the lanes. This is a gel zymography setup. So if you have MMP activity that's elevated, it'll show up as a white bar because it'll start to degrade the gel. And you can do it for different MMPs on the same panel. And here we're looking at MMP9 and MMP2. So in the ischemia reperfusion arm and in the ECMO arm, there's a significant increase in MMP9 activity in the renal cortex. But in the sham and the Impella arm, there's no increase in MMP9 activity, whereas MMP2 remains essentially unchanged across the board. So there's something specific about MMP9 that gets activated in the setting of a heart attack in the renal cortex, as well as in the presence of ECMO. And so ECMO is not protecting against that MMP9 upregulation, but Impella appears to be reducing MMP9 activity in the renal cortex. So MMP9 is linked to inflammation. So we replicated John Barnett's work and essentially showed that levels of inflammatory markers like interleukin 1A, 1B, IL-6, interferon gamma, all had the same pattern of expression with increased levels at the renal cortex after a heart attack, as well as after ECMO. But with Impella, these inflammatory markers were not increased compared to sham control across the board. And this wasn't true for all inflammatory markers, so some of the other ones are shown here that didn't show up as any significant change. But using a multiplex ELISA, Xiaoying was able to quantify about 8 different inflammatory markers to create a panel to see if this is a replicating phenomenon. So to our knowledge, this is the first study that starts to dive into this question of mechanism, as well as to start to explore the impact of acute mechanical support on renal injury. And what we identified is that VA-ECMO, but not Impella, is increasing the urinary KIM-1 levels, which is a highly sensitive biomarker of acute kidney injury that precedes creatinine increase. And we think the mechanism may involve shedding of the KIM-1 extracellular domain from the renal cortex, driven by MMP expression. And so the next step is to start to explore the functional role of KIM-1, and is KIM-1 actually protective? If you keep the KIM-1 around, as in the case of the Impella, do you get better signaling through some protective mechanisms involving STAT3 and HIF1? So with that, thank you on behalf of Xiaoying and all of her work, as well as the rest of the team.
Yeah, thank you very much. It was a very interesting talk, digging into the possibility of the reason why there is some renal protection. Are there questions from the floor? Yes, George.
I just have one comment. It seems to me that there were several studies, there have been several studies that have shown statins reduce the risk of renal contrast-induced nephropathy. And they're not elegant in looking at mechanism, but the assumption has always been that it was an anti-inflammatory. And so I guess, since most patients with coronary disease are obviously on statins, but it may be worth in the studies to look at whether they're statin unable to take or something like that, and how that may interact with your results.
Yeah, I think there's no question. If you start to drive inflammation, you're going to have problems. And so any mechanism that reduces inflammation, I think, is going to be beneficial. What we'll ultimately end up doing with this work as we go forward is try to understand why the renal cortex is in particular sensitive to these changes, and then also understand why there may be a link between the hemodynamics again and this inflammatory response. Is it related or not, like you saw from our myocardial data? But there's a theme that's beginning to emerge, at least from our data sets, and which is that, when we're activating ECMO, we're not seeing the same protection that you might be seeing with Impella. And I still can't fully explain, and we don't understand why it is that the Impella itself would trigger these changes or protect against these changes in the kidney. So more to come on that.
What kind of changes are you seeing when you're measuring venous pressure?
Yeah.
Because I think this is almost paradoxical, because it's probably going down with ECMO and maybe even going up with Impella.
Yeah, so that's why I said 2019, but to answer your question, it's a really important question. What we have done is we're putting pressure wires into the renal cortex and pressure flow wires, and also measuring the extra-parenchymal renal artery and vein pressure and flow, and looking for that transrenal gradient of pressure and flow. And very briefly, what we're seeing is things that we don't understand. And we've been able to replicate it now in about an N of 4 animals. The activation of ECMO is creating a large flow gradient across the glomerulus. We're seeing higher arterial flow, and we're seeing reduced venous flow. And so what we're seeing then is this suggestion about the arteriolar regulation, that there may be a flow-mediated vasodilation in the kidney in response to the ECMO. And then downstream, we may be seeing a clamping of the efferent, so we're seeing a reduction in the venous outflow. Now, the problem is you're pounding a lot of blood into that kidney at a pretty high rate, and you're getting less coming out. I think it may be why we see this autodiuresis initially, and then we see the subsequent kidney injury that occurs with ECMO. And so the next question is, are we seeing an increase in parenchymal pressure as the kidney sits in its capsule and starts to swell, and you develop nephrosarca, and then that swelling may compress down on the kidney and create that cortical injury. So that's the postulate. I don't have enough granularity to it, but I think by the time we meet again, we'll have that data.
Okay, we're a little bit behind time, so very short question.
Yeah, Naveen, do you think, we talked about exosomes and communication between organs. KIM-1 is, interestingly, the HepA viral T-cell mediated mechanism. Do you think the possibility within that short time you have that you're actually having a cardiac communication because of unloading, because the major difference you see between ECMO and Impella is you're actually decompressing the heart.
Yeah, I think, to Qiao's talk, it really hits home the point that in my opinion, there's undoubtedly crosstalk between the heart and the kidney. And so we're trying to set up the correct experimental design to get to that question. It's very challenging when you're looking for a communicating mechanism but don't have one yet. But I definitely think there's crosstalk. I just don't have any data to support it yet.
Okay, thank you, Naveen. Great talk. Thank you.